How do you identify a loose pedicle screw? Well, the conventional definition is that if you see a 1 millimeter halo around the screw, either on a plain X-ray or on a CT scan, then you would define it as a loose pedicle screw, and the incidence is anywhere between 0.8 to 27% in literature, but the incidence is significantly higher in osteoporotic bone and when you use posterior dynamic non-fusion implants. Why do pedicle screws become loose? That's something you want to understand before you want to understand how to salvage them. The most common reason is poor host bone. When there is significant osteoporosis, the pull-out strength of the screw reduces and therefore the screws tend to become loose because they do not have a grip in the surrounding trabecular bone. If the spine is unstable, a lot of cantilever loads go at the bone implant junction, eventually causing lysis of bone around the implant, resulting in loose screws and pull-out of screws. Non-union. If the bone does not fuse, eventually the implant will fail because either with fracturing of the implant or pulling out of the implant. What is a very interesting cause is chronic infection. We all know that acute pyogenic infections which we get post-operative wound infections, implants often become loose. But studies which have shown chronic loosening and then subsequently culture has been done, they have found that there is a 29 to 40% incidence of chronic pyogenic infections. The most common bugs being staph and a very slowly growing organism called as propionobacterium. Misplaced screws, if your screws are not placed properly, they are cutting through the pedicle, obviously the chances of their hold is less and their chances of pulling out are more. Multi-level constructs have a higher incidence of non-union, and we can also sometimes blame the pedicle screw design. If the difference between your outer diameter and inner diameter is much lesser and the helical pitch is very large, then the chances of pull-out are higher. How do you identify pedicle screw loosening? The most common thing which we do is look at standard X-rays, AP and lateral, and the sensitivity of this is only about 55%, not much. But if they are picked up on a standard X-ray, then obviously they are most likely to be loose. CT scan has a much better sensitivity and specificity. The MRI, on the other hand, you use metal artifact reduction sequences, and they tend to help you identify edema around the screw, and that is an evidence of pedicle screw loosening. What has come today is PET-CT. PET-CT is extremely sensitive. If you are suspecting a loose screw, get a PET-CT done, you'll find increased blood flow around that area. It is 100% sensitive and extremely specific, one of the best tests that is available to identify pedicle screw loosening. However, you must remember that all loose screws are not symptomatic. And every time you see a loose screw, do not panic and start wanting to do something about it. You may wait, fusion may occur, and things may collapse and settle down on their own. Occasionally, the patient will complain of mechanical back pain. They may have screw pull out, in which case the implant becomes more prominent under the skin, and there may be construct failure with recurrence of deformity. What are your salvage options? Your salvage options are three primarily. You could go through the original track, but you'll have to do something because the screw hole has become bigger than normal. You'll have to use some methods to reinforce that pedicle screw tract. You could change the screw trajectory, or you could change the screw design geometry. But remember that your screw has loosened because there is an underlying cause in most cases. Either your anterior column reconstruction is not adequate and therefore it's putting a lot of load on the screws. Your fusion has not occurred and therefore eventually the implant is giving away. Or there is severe osteoporosis and that's why the implant is pulling out. And therefore you need to treat the cause along with the change of the screws. Reinforcement of the original pedicle tract is a very well-known thing. Since the good old days, people have been using a variety of different material. You could use autograft, you could use allograft, hydroxyapatite. What you do is you put it in a bone mill. You make it powdered like I've shown over here, and then using a funnel, you actually pack the entire pedicle screw tract with the bone graft and then put your screw in, and it gives you a 70% increase in bone strength. I mean the bone pull-out strength. The second option for us in the reinforcement of the original pedicle screw tract is what all of us have ubiquitously started using, and that is bone cement. Bone cement can be inserted the tract can be pre-filled with cement, which is better than using a fenestrated screw. The second option is using a screw which has holes in it and then putting it in and then injecting cement. These increase the pull-out strength by almost 170%, but it does carry the risk of leakage of cement and neurologic deficits, etc. The other problem with the fenestrated screw is it just holds the screw distally, and proximally there is a toggle or a cantilever force which is being applied, which can cause failure of the implant. The next thing, of course, is to change the screw tract. You can start with a different entry point if it's possible. You can go more medially, more laterally. You can go more cephalad, caudate, depending on what you want to do and what is available. In the thoracic spine, if you've gone by the standard straight-in technique, you can change the technique and go via an anatomic trajectory which goes up from the cephalocaudate direction. Or you can go via the in-out-in technique, which is extrapedicular, which will also help you to improve the bone grip. The other method which has been described is cortical screws. The typical pedicle screws are medial and go straight in. The cortical screws go laterally, getting purchased in the pedicular bone, and that causes an increase in the pull-out strength, which is 70% more than the pull-out strength of cancellous screws. Finally, looking at screw designs. So instead of using your regular screw, you could use expandable screws which have a better grip within the bone. You could use screws of a larger diameter. They work much better than a longer screw because the screw hold is mainly in the pedicle, not in the vertebral body. So increasing the length is not going to help as much as increasing the diameter of the screw. But if you increase the length, you should try to achieve a bicortical purchase, which will increase your pull-out strength significantly. Finally, you can supplement your instrument construct with a variety of different designs. As I mentioned, anterior column reconstruction is vital. You need to convert implants from being load-bearing to load-sharing so that the fatigue failure of the implant is reduced. Remember, from the time you insert an implant into the body, there is a race between implant failure and fusion. If fusion does not happen, eventually most implants will fail. Then you do not blame Jesco, do not blame Uma Surgicals. It is your skill which is in question. And finally, of course, you must remember enhancing bone strength. One of the best drugs available to do that is teriparatide. Lot of people are giving post-operative denosumab, zoledronic acid, but that does not. First and foremost, it to some extent retards fusion. And second is, it does not rapidly increase bone strength enough to give you a help with pull-out. If you want to do that, you need to give teriparatide, ideally pre-operatively, but if not, at least start it post-operatively and do the needful. So finally, to conclude, what are your options when you land up in a problem with loosening of screws? Very simply, reinforce the original pedicle screw tract. If that doesn't work, change your screw trajectory. If still that is not possible, then you can attempt to change the screw design. You can also supplement screws with other implant systems. And remember again, treat the cause. Without treating the cause, you will again have loosening of your implant if you've not done a proper job. Thank you very much.